Dr. Abrar AlAbdulhadi, who will be discussing common pediatric cases seen in primary healthcare. Dr. Abrar is graduated from Temple University School of Medicine in Philadelphia. She completed her general pediatrics residency at the Children's Hospital, Philadelphia. Dr. Abrar currently working in the pediatrics department at Amelia Hospital. Please join me in welcoming Dr. Abrar. Dr. Abrar, حياك الله.
الله يحييك مشكور. Let me
الله
just share my screen. Can you all see my screen now?
Yes.
تشوفونا من غير النوت صح؟
Yes.
Okay, خوش. بسم الله الرحمن الرحيم. اسمي دكتورة أبرار, and today I'm going to be presenting some multiple choice questions going over some pediatric cases. And although this title is a joke, when in doubt, pick C. I think in pediatrics, if you're faced with a review question and you're really not sure what to pick, you can always pick reassurance or the least invasive. So let's move on to our next slide. I have nothing to disclose. We have a list of topics that we're going to review that was set aside by your scientific committee very kindly. We're going to go through some nice guidelines that are related to these topics, and then I'm going to reintroduce for some or introduce to some of you Miss Rachel and Bluey, who are some giants in pediatrics. So the questions that we're going to use today are from the American Academy of Pediatrics Prep Question Bank. I use this slide to remind you all that practice questions are learning tools. I don't think I've ever gone through a question bank where I have passed the question bank. The goal is to use them as learning opportunities, and I want you all to keep that in mind when we're going through the questions today. We're not going to go through any of these topics in details. We'll more go through some broad strokes and how to approach the questions themselves. All right, so we'll get started off with our first question. We have a previously healthy 2-year-old boy who's being evaluated in November for an abrupt onset barking cough, voice hoarseness, and respiratory distress. 2 days ago, he developed rhinorrhea. His immunizations are up to date, and on physical exam, his temperature is 38 degrees Celsius, heart rate is 141, respiratory rate is 24, oxygen saturation is 94% on room air. Your examination reveals yellowish nasal discharge, inspiratory stridor, mild suprasternal retractions, but no cyanosis. The stridor worsens when the patient is upset, and the rest of your exam is normal. So of the following, the most likely pathogen causing this child's illness is influenza virus, parainfluenza virus, respiratory syncytial virus, or Staphylococcus aureus. So take some time to answer the question. All right, great. So it looks like most of you got this. So our case is a case of croup, and the most common cause of croup is parainfluenza virus. All right, so we'll move on to discuss croup for a few minutes. So the big fancy name for croup is laryngotracheitis, and basically all that means is that we're dealing with the upper airway, not the lower airway. The peak incidence is from 6 months to 3 years of age. And as the question was alluding to, the most common cause is parainfluenza virus. However, if you were to take a nasopharyngeal swab, you would commonly find other respiratory virus as a co-infection as well. It's a clinical diagnosis. We'll go through in a few slides what the chest x-ray may look like in terms of classical findings. However, you don't need a chest x-ray. You don't need to confirm that it's parainfluenza virus. You can just hear the cough and diagnose it. However, whenever we have something that's a clinical diagnosis, we want to take really careful history and physical exam to make sure that we're not missing anything, because our differential can include bacterial tracheitis, RPAs, epiglottitis, foreign body aspirations. So we really want to make sure that you're dealing with group, especially when we don't have a specific laboratory or chest X-ray diagnosis that we need to do. So things that you want to pay attention to in your history, the main thing I would say in this age group is foreign body aspiration. Sometimes we'll get lucky and the families will say, oh, I didn't, I looked away from the child and I heard him choking, or I saw him put a coin in his mouth. Sometimes we'll get lucky with that history, but more often it's very vague. So you really want to ask, was the child ever left alone, even if it was just for a few minutes as the parent went to go get something? Were there preceding URI symptoms, or was it sudden onset cough? Because when you have a history, when it's sudden onset cough or sudden onset choking, sudden onset vomiting, those could all be signs of a foreign body aspiration. And the main thing in the past medical history that you want to make sure that you asked is a vaccination history to make sure we're not missing epiglottitis, and any history of prior intubation or airway surgeries, because this may allude to tracheal stenosis as your diagnosis. Red flags for this might not be your right diagnosis is if a kid is coming less than 6 months with this diagnosis, greater than 6 years with this diagnosis, and especially if someone's coming to you with recurrent group. If someone's coming in every month in the winter with this barking type cough, if the cough is lasting for greater than 10 days, the stridor is lasting for greater than a week or so, those are your red flags that this is not group that you're dealing with. When it comes to treatment, really what we want to see is stridor or no, is the stridor happening at rest, or is it happening when the patient is upset? Because that'll help differentiate the severity and our treatment courses. All comers will get oral dexamethasone. Per the NICE guidelines, they'll get 0.15 milligrams per kilogram. You'll often see us in pediatrics when they come to us in the emergency room or on the ward, we'll give 0.3 mg per kg or 0.6 mg per kg. Those are just differences in guidelines, the AAP guidelines and the Canadian guidelines. If they have stridor with agitation, if they have stridor at rest, then you want to give nebulized adrenaline. If you're giving that in your clinics, then you want to be thinking about admission at that point. Usually in the emergency room, we'll monitor them for about 2 hours. If they're needing repeat, then they'll get admitted. And of course, main thing to focus on is supportive care, mainly hydration, because the cough can really irritate that upper airway and cause our kids not to want to drink. So we'll go through what the cough sounds like. Often our very savvy parents will diagnose this themselves at home. As you can see, it's almost like a bark seal type cough. And then this is what stridor is going to sound like.
Shit, baby. Yeah, so we can go see the doctor. Poor sweetie.
As we can see, this baby is at rest. He's not upset and crying, and he's making these noises. So this would be stridor at rest, and this baby would need nebulized adrenaline. So this is where timing is really important. As soon as you try to do a doorway exam, like before you come in and the kids get scared, see what the patient is doing while with their parents and at rest. Because as soon as you walk in and they start crying, then you've kind of lost your physical exam at that point. Because the immediate decision that you want to make is this child sick? Do they need nebulized adrenaline, or can I treat them with steroids in my clinic? All right, and if you do get a chest X-ray, this is a classic sign called the steeple sign. But again, this is a clinical diagnosis, so you don't need a chest X-ray to diagnose it. However, if there's any doubt about the diagnosis, you're worried about foreign body, then get a 2-view chest X-ray as your next step. All right, we'll move on to our next question. We have a 30-month-old girl who's being evaluated for loose stools. She started toilet training at 24 months of age, but has not yet achieved daytime continence, which has frustrated her parents, understandably so. For the past month, she's had 1 to 2 large, hard stools per week, While stooling, she hides in the closet and refuses to stool on her potty. Over the past week, she's had daily large volume, non-bloody loose stools. She eats a regular diet for her age and drinks about 1.2 liters of low-fat cow's milk per day. She's been growing and developing well. She appears well and is not in any distress. Her abdomen is distended but non-tender. There's a large amount of stool palpable in the left lower quadrant. Rectal examination reveals a normal appearing anus with brown soiling present, normal anal wink, and a dilated rectal vault with palpable hard stool, which is a very detailed rectal exam. I think a rectal exam like that comes with a GI fellowship. But of the following, the most effective recommendation to manage the patient's condition is to decrease milk intake, delayed toilet training, decrease her fiber intake, or initiate a laxative. We'll take some time to answer. All right, great. So it looks like most of us got the answer. So our answer is going to be to initiate a laxative. So this child has constipation. When you're reading a question stem about constipation, in terms of trying to pick the answer that has the most effective recommendation, your branch point is going to be whether the child has fecal impaction or not. If the question stem is trying to point you towards fecal impaction, then you want to move towards the answer choices that include a laxative. If they're giving you mild type of symptoms without impaction, then you can choose the answers that involve lifestyle modification, like decreasing milk intake, toilet training, fiber intake, all those kind of things. But as soon as you start to get the vibe or the gist that they're talking about fecal impaction, then you want to pick laxative. So what is pointing us towards fecal impaction in this question stem is that this child has a distended abdomen. You feel stool in the left lower quadrant, so there's a significant stool burden, and your rectal exam reveals hard stool, and she's having loose stools. So if you're doing a rectal exam and you feel hard stool, and there's a history of loose stools, that means there's a large stool ball impacted in your anus, and there's overflow diarrhea that's happening around that stool ball. So that's what's telling us that this is a case of fecal impaction. Of course, you want to be decreasing her milk intake to less than a liter per day, closer to 900, 950 mLs. You don't want to be toilet training when the child is acutely suffering with constipation. We want to increase, not decrease her fiber intake. But these lifestyle modifications can happen simultaneously as you initiate a laxative, but you want to focus on clearing out the obstruction first. So we'll go through one more question and then we'll talk about constipation in a little bit more detail. So we have an infant that's brought to the office for her 2-month health supervision visit. The mother is concerned because the infant stools every 4 days. The stool is soft without any blood or mucus. There is no significant straining with passage of the stool. The infant breastfeeds for 10 minutes every 2 to 3 hours. Her weight is along the 40th percentile for her age since birth. Of the following, the best next step in management of this child is milk elimination, mineral oil daily, polyethylene glycol daily, or reassurance. We'll take some time to answer. Right, so most of us got it. And like we said in the beginning, when in doubt, pick reassurance or the least invasive option. So for this question, this is a breastfed baby is the main thing to keep in mind. For breastfed babies, in the beginning, they will stool with every feeding session, and then around the 1 week, 2 week mark, they'll start to develop their own stooling patterns. Some breastfed babies can go up to 10 to 14 days between stools and not have any issues. So where they're trying to reassure you is the fact that this is a breastfed baby, and the fact that there's no straining and the baby is tracking along their weight percentile. So all these things reassure you that this baby is okay and does not need treatment. Since there's no signs of constipation, B or C are incorrect, so we don't need to treat for constipation. A is pointing towards colitis. So if there was any history of bloody stools, poor weight gain, then this baby's mother would need a milk elimination diet. All right, so we'll talk about constipation briefly. Again, this is a clinical diagnosis. You will often see people get abdominal x-rays to assess for stool burden. This is not necessary nor recommended. What you really want to focus on is the type of stool. So if you see here on the right, there's the stool Bristol chart. The first two, so those hard lumps, that sausage shape, those are constipation. Our type 2 and 4, our type 3 and 4 are normal, and then the other types describe diarrhea. There's a technical definition to constipation. So you need at least 2 criteria with less than or equal to 3 stools per week. Of course, not applicable to breastfed babies. You want a history of stool retention, hard stools to pass, straining, large diameter stools that are hard to flush. There's all these like specific criteria. But really, when it comes to taking your history, what you want to focus on are the presence or absence of any red flag symptoms. Because when someone comes describing a history of constipation, it's a pretty easy diagnosis to make. But what you want to do is make sure that you're not missing an underlying cause that requires referral to a subspecialist. Because most cases will be just functional constipation that we can manage in the clinic. But some of the red flags to keep an eye out for are onset within those first few weeks of life, delayed passage of meconium for longer than 48 hours. Those babies can have things like CF, Hirschsprung, malrotation, abdominal distension with vomiting. That can be a sign of obstruction and severe constipation, a family history of Hirschsprung disease. Often kids with full-blown Hirschsprung's disease will fail to pass meconium and will get diagnosed in the nursery period. However, there's a subset of Hirschsprung disease called microsegment Hirschsprung disease. Those kids will often get missed and diagnosed later on. Leg weakness or motor delay, that's pointing you towards a neurologic cause for the constipation. And of course, on your physical exam, if you see abnormal positioning of the anus, abnormal anal or rectal tone, lumbosacral abnormalities that could point you towards undiagnosed or late diagnosis of spina bifida, any gluteal region abnormalities as well. When it comes to treatment, like we said in our questions, the main thing that you want to ask yourself when you're examining the patient is, do I have fecal impaction right now or no? Because if you do have fecal impaction, then you're going to be, when you look at laxative dosing guidelines, there'll be a column for fecal impaction, and then there'll be a column for maintenance therapy. So if you have suspicion of fecal impaction, go heavy first and then go towards your maintenance therapies. You want to be focusing on lifestyle modification, of course, making sure there's enough fluid intake, there's good fiber intake, good fruits and vegetables. In terms of behavioral modifications, a stool diary, planned bathroom visits, so going to the bathroom and sitting on the toilet for 10 to 20 minutes after every meal can help get the child into that routine. Really focusing on positive reinforcement. Often parents will be frustrated by their child's actions, but remind the parents that this is not a voluntary thing that they're doing. But if the parents do turn this into a negative experience, there will be that power struggle. Because as we know, 2-year-olds, 3-year-olds can be terrorists. And if they feel that they can manipulate you with their stool, they will. So really making sure that we're focusing on sticker charts, lots of positive reinforcements, and not putting anything that has to do with punishment or fear or shame into this experience. And when a child has a constipation, we do not toilet train, not until we make sure that the child is having daily soft stools, either with a laxative or without. There's no stress within the environment. There's no big upcoming changes. Then we try toilet training again. In terms of medications, I was taught that there's two big classes, the mushers and the pushers. So the mushers are your osmotic laxatives. They're going to make the stool more mushy. That's our Movicol, that's our lactulose. And then our pushers are our stimulant laxatives, so Senna, Docusate, Bisacodyl. Some guidelines will tell you to start the musher or the osmotic, and then if that doesn't work after 2-3 weeks, then to start a stimulant. I was taught to kind of do both in the beginning and then take away the stimulant after a few weeks once things are moving in the right direction. Because when you have chronic constipation, you can have kind of almost like a megacolon and a lazy bowel. So see what works with your families. When to refer, of course, if you see any red flag symptoms, if you have persistent fecal impaction that's not improving in the outpatient setting after about a week or 2 weeks. If kids are less than 1 year old, give them about a month on laxatives. If they're older than 1 year old, give them about 3 months before referring over to pediatrics or GI, depending on where you are. But really what we'll see in clinic is they'll do well on Movicol, and then parents will stop it and then come back and say that it's not working anymore. When we really want to gradually wean the child off of it, and it's okay for the child to need Movicol for 3 months, 6 months, up to a year before developing their own stooling pattern off of it. So it will be a trial and error of kind of weaning off and putting back on. All right, so we'll move on to our next question. We have a 4-year-old who's being seen in clinic for evaluation of a 3-month history of abdominal pain and diarrhea. She has 5 to 8 loose, malodorous, floating, greasy appearing stools daily. She lost 5 kilos unintentionally during the 3-month period. Her physical exam reveals a weight of 14.5 kilograms, which is the 24th percentile for age. Height is 100.5 centimeters, which is 44th percentile for age. She has a BMI of 14.4, which is the 19th percentile. She appears pale. Her abdomen is distended but soft and non-tender. The remainder of the exam findings are unremarkable. And when we look at her labs, we have a stool pH of 7, no blood, ova and parasites are negative, no stool culture is negative, her hemoglobin is a little bit low. And then we have a vitamin D that's a little bit low and albumin that is low. Or albumin is normal, my apologies. So we'll go through some of our answers. All right, great. Yes, gluten-free diet. Okay, so let's go through why. So this child has celiac disease, and going through the question stem. So she's losing weight. She has evidence of fat malabsorption in that she has greasy floating stools, and she has low vitamin D, which is a fat-soluble vitamin. She's losing weight. She appears pale with a low hemoglobin. Although there is not like one single slam dunk that points us towards this is celiac disease from the presentation, it's pointing us towards malabsorption, and we can kind of do a process of elimination for our answer choices. She doesn't need albumin. Her albumin's normal. There's nothing in the history suggesting that lactose is a trigger. So lactase enzyme replacement is not our answer. So that kind of low sucrose diet, I'm not sure what they're trying to point towards. Celiac disease would kind of be our next best guess, which points us towards gluten-free diet. This is dermatitis herpetiformis, which you can see on physical exam for some of our celiac patients. But really a lot of celiac within this age group will just present with failure to thrive and anemia. All right, so we'll talk about failure to thrive a little bit. Celiac disease is on the differential for failure to thrive. The main thing is that failure to thrive is an umbrella term. It is not a specific diagnosis. When we say failure to thrive, we are saying that this child needs further evaluation. We don't diagnose failure to thrive as a final diagnosis. We want to think of the etiologies for failure to thrive in three broad buckets. I was taught the leaky bucket analogy. So there's three main categories for the etiologies of failure to thrive. And if we think about it like a bucket, there's either not enough coming into our bucket, we have a leaky bucket, so there's too much coming out, or we're burning off too much. So let's go through each of these one at a time. Most common, it's going to be not enough in. So our first category, we don't have enough calories. So is it a swallowing issue? Is it a psychosocial issue where they don't have enough formula? Do they not know how to mix formula? Is it a breastfeeding supply issue? Is it constipation leading to decreased appetite? Is it a severe picky eater? So those are going to be our most common etiologies for failure to thrive. Next, we go into too much out. Are they losing too much? Is it a malabsorption issue like celiac disease, like IBD, milk protein allergy, cystic fibrosis? After that, our option is burning up too much. Is it a calorie expenditure issue? Things like hyperthyroidism, malignancy, heart failure. So those are going to be our next bucket. There's different approaches for failure to thrive. Some people will do a shotgun approach and send a whole battery of tests from the beginning. I was taught or trained to kind of go with the first bucket first, so our not enough calories. Of course, first you're going to do a very thorough history and physical exam. If nothing is standing out to you, like let's say, for example, there's a murmur and a liver edge. There you go. It's probably heart failure. Then go into this last category, burning up too much. Get an echo, treat the heart failure if it's there, and that takes care of your diagnosis. They're coming in with microcephaly, tone issues. It's probably a neurologic metabolic cause that's going to lead your the diagnoses there. But if everything appears normal, you don't have anything kind of jumping out at you, instead of doing a whole battery of tests from the beginning, tackle that first issue first, which is not enough calories. Do a direct feeding observation, take a detailed dietary history, fortify calories, see if that helps solve the issue, have them come back daily for weight visits, and see if you can take care of this as an outpatient. If you're not seeing improvement after a couple of weeks, then this can be like an inpatient workup type of issue. But your main diagnostic tool is going to be your history and physical. And remember to always check your weight, height, and your head circumference. Because your usual drop-off order is going to be your height comes down, then your weight comes down, then your head circumference. If you're starting to see decreases in height, then that's severe malnutrition. Those kids need to be admitted for further workup and for intensive dietary intervention. Those are usually the kids that we're doing a thorough endocrine workup. We're considering NG tubes because they've been severely malnourished for a long enough time that it's starting to affect their height. If you have drops in your head circumference first, before your height or before your weight, then that's a red flag for neurologic issues. So that's why it's really important to kind of check all of your growth parameters and make sure that it's falling in the expected order. Just a couple of reminders about failure to thrive. As we all know, it's okay to lose weight in the beginning, up to 10%. Make sure, though, if you're getting close to 10% or higher, that you're carefully monitoring your neonates for signs of dehydration. You always want to balance your family feeding preferences. Fed is best, of course, and we want to help support families in whatever they choose in a non-judgmental way. You want to watch for crossing percentiles. Those need more urgent intervention. You want to do a detailed dietary history like we discussed. If they're less than 1 month old, bring them back to clinic at least daily for weight checks. If they're older than 1 month, you can do weekly weight checks. Older than 6 months, you can do weight checks every 2 weeks. Monthly if they're older than 1 year. Your height, you're really going to be monitoring every 3 months or so. And again, your treatment's going to depend on your underlying diagnosis. All right, so we'll move on to our next question. So we have a 6-year-old who's being seen for a routine health supervision visit. Mom is concerned because the girl's been wetting her bed for the past few weeks. She's dry during the day. She's had no fever, no increased urinary frequency, and no burning. She has been completely toilet trained since she's about 4 years old, and she does not awaken when she wets the bed. Sometimes she snores, she seems more tired in the mornings, and her physical exam is normal except for some tonsillar enlargement. So of the following, the most appropriate next step is? All right, great. So the answer is to refer to an otolaryngologist, a very long word for ENT. But basically what this question stem is trying to get us towards is the fact that we always need to, when we diagnose nocturnal enuresis, we always need to consider is there an underlying cause? So let's go through this question stem. We have a 6-year-old, so she's over 5 years old, so we're good. We can diagnose enuresis. Sometimes you'll have people in clinic, parents coming in clinic, the child is 3, 4, just turned 5, and they're concerned about enuresis when really they just have unrealistic developmental expectations for their children. So you want your kid to be at least older than 5. This kiddo has secondary enuresis because she was dry and then now she's starting to wet the bed. We have no symptoms of fever or UTI, so we don't need antibiotics. Answers B and D, proper sleep hygiene and bedwetting alarm, are correct if there was not an underlying etiology to this. So the question stem is pointing you towards that this child snores when they're sleeping and that they have enlarged tonsils. So that's pointing you towards OSA as the underlying, or obstructive sleep apnea as your underlying diagnosis. So they need referral to an ENT, plus minus a sleep study. So if sleep study was one of the options, they probably wouldn't have put the referral there and you would just pick sleep study. So untreated OSA can lead to fatigue, daytime fatigue, hypertension, right-sided heart failure, and enuresis, as well as ADHD. It's unclear exactly how OSA causes nocturnal enuresis. There's some studies that suggest maybe it's an issue with the sleep-wake pattern. However, if you do have a child coming in with nocturnal, especially secondary nocturnal enuresis, you always want to take a detailed sleeping history to see if they've been snoring. So we'll go through a little bit about nocturnal enuresis. You want to make sure that the kids are at least 5 and older. You want to differentiate primary from secondary. Have they never been dry and it's primary, or is it a secondary? So they were dry before and now they're urinating. But to call this secondary enuresis, they need to have been dry for at least 6 months. You want to take a comprehensive initial assessment, a very detailed history about fluid intake, caffeine intake, toileting pattern. Are they going to the bathroom before bed or not? Are they dry during the day or not? In terms of your differential diagnosis, you want to make sure they're not constipated because that can lead to abnormal urination. You want to make sure there's no signs of UTI, no signs of diabetes that could be explaining your enuresis. And of course, making sure there's no signs of child abuse, especially sexual abuse. There's some relation to genetics. If one parent wet the bed after 5 years old, their kids will have that same issue about 40% of the time. If both parents had this issue, there's a 70% chance. And for monozygotic twins, there's a 68% concordance and 36% in dizygotic twins. It can be related to stress. There's some debate over whether it's related to deep sleep, like, oh, my kid sleeps very deeply, that's why he urinates the bed. That's a little bit debated. OSA, like we talked about, in constipation. In terms of our treatment options, sleep hygiene is very important, making sure that there's no fluids about 2 hours or so before bed, making sure they have adequate hours of sleep, asking parents to try to wake them up around the middle of the night to go to the bathroom. That may help as well. Bed alarms help. So parents will often buy them online. Once the alarm sense wetness, it will create a loud noise, and some will even shake the bed. And the idea is that with time, if this happens every time the patient wets the bed, then they'll almost be like rewiring of the brain, where as soon as the bladder is full, it will wake the child up, being afraid of the noise. And then for kids older than 7, we can use desmopressin, which is a synthetic ADHD analog. It works at the level of kidney to reduce urine output overnight. It works about 60 to 70% of the time. There is a risk for hyponatremia, so you want to make sure that you're talking to parents carefully about fluid intake. All right, so we'll go through our last question here. We have a 15-month-old, full-term, developmentally normal child who's brought to the emergency department after having a first-time seizure. The girl was in her usual state of health, and then she became unresponsive while playing, stiffened, and had rhythmic shaking of all of her extremities. Her eyes were open and staring straight ahead. The episode lasted 8 minutes before self-resolving. Immediately afterwards, she was sleepy and warm to touch. There is no family history of epilepsy and no known sick contacts, but she does attend daycare where there are multiple sick contacts at all times. Her immunizations are up to date. On physical exam, the girl has a temperature of 39 degrees Celsius, heart rate is 110, respiratory rate is 28, her blood pressure is 95/58, and her oxygen saturation is 100% on room air. She's initially sleepy but arousable, and shortly after arrival to your clinic, she starts to play with her stuffed animal. Her right tympanic membrane is erythematous, bulging, and opacified, and the rest of her exam is normal. You give her an antibiotic. What are you going to do next? All right, so most of us got this right. The answer is going to be to administer an oral antibiotic. So we'll go through febrile seizures, but this child had a simple febrile seizure in the setting of acute otitis media. And when you have a simple febrile seizure, you want to treat the underlying reason for why they had the seizure. So you're going to give her an antibiotic, amoxicillin, to treat her ear infection. She's no longer seizing, so does not need an IV benzodiazepam. And when you have a simple febrile seizure, you don't need further workup with a head CT or routine EEG, especially if they've come back to a baseline. Whether you refer them for admission or not, that's going to depend on your individual clinic protocol, as well as the individual hospital that you're at. So the hospital where I work at, Amiri, first presentation of simple febrile seizure, they'll get admitted for observation, but I know that there's other hospitals in Kuwait who, if it's a simple febrile seizure, they will not admit. So let's go through a little bit about simple febrile seizures, febrile convulsions in general. Your age group is going to be 6 months to 5 years. If they're older than that, if they're younger than that, then it's likely something more complicated. Your care is going to be guided by your history and your physical exam. About a third of these kids will have a positive family history of febrile convulsion, and 1/3 will have recurrence. That's the parents' big question: is this going to happen again? And that's usually I tell them, like 1/3 will have another one, and 2/3 will not have another one. The third that do have another one usually are the ones that have their first one when they're less than 18 months. There's a family history of febrile convulsion. They had a lower grade fever with the onset, so almost like a lower threshold. They have a history of a complex febrile seizure, or they're in daycare, which there's just lots of viruses in daycare. The other big question that families will ask you is, does my child have epilepsy? Is this going to be a long-term condition? There's only a slightly higher rate of epilepsy than the general population, so I will usually reassure and tell them that not necessarily are they going to have any long-term issues. Most just outgrow this by the time they're 5 and not have any issues again. And I like to reassure my families that this is especially in the case of simple febrile seizure, this is a normal response for your child's brain. We don't know why we think it's genetic, but we don't know why some kids will have seizures with fevers and some kids will not. But the seizure itself is the body's reaction to a fever, and not necessarily that there's anything wrong with your child. Most commonly, this is due to a viral infection. There's some association with MMR and DTaP vaccines, but it's not a contraindication. So even if they do have a febrile convulsion after MMR or DTaP, that's not a contraindication to later doses. You want to take a very detailed developmental history, a vaccination history, and an antibiotic exposure history. And the reason being, if your child has developmental delay, then that can be pointing you towards, is this part of some sort of syndrome that's leading to seizures and developmental delay? So you want to keep that in mind. Your vaccination history and your antibiotic exposure history are important, because what we're trying to figure out is this due to an ear infection, a virus, or is this seizure due to meningitis? And if they're coming to you and they're not vaccinated, or they've had a week of antibiotics before coming, you could have partially treated meningitis, and those kids will need lumbar puncture and admission for IV antibiotics. So that's why that history is really important, and it'll push you towards referring for admission if you see that present. The other big thing that we're trying, of course, the other question the parents will have is whether they should give around-the-clock Adol or Profen with later illnesses to decrease seizure risk. Studies have not shown that that helps. So we don't routinely recommend that, although I know a lot of parents will still do that. The reason being is that it's not like the degree of temperature is directly related to the chance of having a seizure. So even if you keep the kid from becoming 38 and above, that doesn't necessarily mean that they're not going to have a febrile seizure at a lower threshold. And you run the risk of having the parent give them around-the-clock Adol and Profen for several days at a time, leading to liver injury or gastritis, depending on the doses that they give them. And per AEP guidelines, for simple febrile seizures, you don't need the routine evaluation. You don't need EEG, neuroimaging, CBC, electrolytes, really anything. You can just diagnose it from physical exam. But the main thing that you're trying to differentiate is this a simple febrile seizure, or is this a child with an epilepsy syndrome, and this is their first presentation of seizure in the setting of a viral infection? Because we know that kids with epilepsy are going to have more seizures when they're ill, because they have a lower seizure threshold. So when a kid comes to you with a history of febrile seizure, it's easy. It's a simple febrile seizure, halas. When they're coming to you with their first episode, it can be a little bit tricky, which is why it's really important to do serial exams, to take a very detailed history. More often than not, by the time they come to you in clinic, they've returned to their baseline, they're playful, you see an ear infection, you see tonsillitis, halas, your diagnosis is there, and they're doing okay. You can give reassurance and guidance for the family, and most often you won't see them again. It's the ones that kind of fall in that gray area where they're not 100% back to normal, the parents aren't super comfortable, where you just refer them in and we'll watch them for a day or two and see what happens.
Dr. Abbas, before interrupting you, have 5 minutes.
Okay, thank you so much.
Thank you.
In terms of our classifications of our seizure categories, we have simple febrile seizure, complex febrile seizure without concerning features, and complex febrile seizures with concerning features. So those are your 3 broad categories. And as we can see here, simple febrile seizures, that'll be less than 15 minutes in duration. There's no focal findings. There's a single seizure in 24 hours. You don't need any meds, and they've returned to baseline. It's complex if they have more than 1 in 24 hours. And then it's complex with concerning features if it's greater than 15 minutes, or it's greater than 5 and they needed benzo. If they have any type of focal features, so it wasn't a generalized tonic-clonic type of seizures, or 3 or more seizures in 24 hours, and they have not returned to your baseline. We categorize them this way because the guidelines differ in terms of what kind of workup that you need for each category. So often they'll say with simple febrile seizure, you don't need any workup and you don't need referral to a neurologist. With complex, they'll recommend maybe an outpatient EEG, seeing a general pediatrician to follow their development. And then with complex febrile seizure with concerning features, those are usually the kids that will end up getting an outpatient EEG, maybe an outpatient MRI as well. Sometimes they'll get referred to neurology if there's developmental delays. So it just helps us risk stratify these patients. The big thing that we want to talk about with our families is seizure first aid. How do you take care of your child when they have the seizure at home? Because most often with the first one, they'll panic and we want them to be ready for the next one. Hopefully it doesn't happen, but as we know, in a third, it will happen again. So the main thing is to lay the child gently on their side and remove any obstructions from around them. If there's toys, if there's a table or something near them, remove everything to give them space so that they don't harm themselves. And remind families not to put anything in the child's mouth. There's still some families who will believe the old movies where they'll put a toy or their hand or a wallet in their mouth to keep them from biting their tongue, which will just lead to obstruction and vomiting. So remind them not to put anything in the child's mouth, just lay them on their side to help with the choking risk. Don't hold the child, so don't hug the child, leave them be so you don't cause injury. Don't give the child any Adol or Profen while they're actively seizing. You'll be surprised. Some families will try to do that to bring the fever down. Don't throw water on the child to try to bring the fever down because you risk aspiration. Mainly just leave the child alone, watch them carefully, and set a timer. If it's lasting greater than 5 minutes, call for help. If the child looks like they're not breathing or blue, then call for help. If this is not their first presentation of febrile seizure, they can watch them at home. There's no need to bring them to clinic or to the ER. If they have another one within 24 hours, then they should bring them to the ER for evaluation. If the fever is lasting for more than 3 days, they should bring them for evaluation. But if it's just oftentimes you'll see is after the parents get the diagnosis of simple febrile seizure, they'll just manage this at home. The kid will have a seizure with a virus every now and then as long as they don't have another one, they'll just watch them at home and you'll never see them again. But really what you want to tell them is if it's lasting then more than 5 minutes, if you're having more than one a day, bring them in to be seen. And that is all I have. This is Bluey. Bluey is wonderful. He's an Australian sheepdog. It's a great show that the kids will watch these days. I highly recommend. So you can use it to kind of connect with your patients. We don't like Cocomelon anymore. Cocomelon is too stimulating. So Bluey is the way to go now. And then this is Miss Rachel. She's a speech language pathologist who has some great videos on YouTube and some great songs for little ones as well. And that is all I have. Let's see if there's any questions.
Thank you, Dr. Abrar, for your insightful and comprehensive lecture. You truly explained many important topics in pediatrics. It was explained clearly to us and making them accessible for all of us. We truly appreciate your expertise and the practical tips you shared.